I noticed that it's easy to talk about research and that within what you might call the clinical space. In the softer spaces where we're talking about the human interaction and the clinical benefit through that. And I'm a chaplain, and just a little bit of background about me. I've been a chaplain for nearly 4 decades, and I'm also a trainer of chaplains through the Sydney College of Divinity at master's level. And I observe that, as in my first question, that many of my students talk about what they do at the bedside, and we use a bedside learning model, experience very positive responses from patients who don't realise they're actually receiving pastoral or spiritual care. And even when they've received it and we go away, they would not be able to answer a question about that. I guess I'm struggling with understanding how to generate research in that space, and I struggle to understand the mindset of researchers within the health space, which seems to focus only on clinical, hands-on surgery, that kind of thing. Is there a way of expanding the vision? Because the evidence that I'm aware of is that our pastoral care, and that's where my area is, pastoral care provides a $1.6 return for every dollar spent. It shortens, good quality pastoral care will shorten a stay by 1.25 days for many patients. So we are financially viable, but not considered. And the research says that it's because there's a fear that funding for clinical stuff will be taken away if we send it to the softer spaces, but the softer spaces don't attract the research. So we can't actually demonstrate the evidence within a health context or something that is acceptable to the health context. Any comment there?
I think I'll jump in here. That model of care that you're describing, Frank, reminds me a bit of the sort of movement that's happening within the psychological support space, where to declinicalize care and involve more peer support groups and online communities, and that sort of approach. And I mean, just talking specifically about discrete choice experiments, there are papers out there that look at comparing these different types of scenarios and these different types of settings of delivering care and ways of delivering care to people. And when you're doing it with a discrete choice experiment, for example, you don't have to explicitly tell people, you know, would you prefer pastoral care versus clinical care? You can create 2 different scenarios which comprise, you know, features that you would experience in pastoral care and you would experience in clinical care. And you're getting people to decide between which scenario they prefer. You're indirectly getting information about those features that are important to people. And that might be one way of getting around that kind of sort of effect that you're seeing, where people might not be explicitly able to say, you know, this specific type of care is what I prefer, but this feature is something that I appreciate or I found helpful.
Thanks, Laura.
John, I'm going to have to step back to clinic if that's all right. But thanks for the opportunity to present and to be part of this.
Great. Thank you very much, Nick. Take care. Okay. I don't see, tell me, but I don't see any additional questions.
No, we had that extra comment in the chat, which was for Frank. Just someone offering some ideas there. But I think we've covered off all of the chat and we're within time of the session. John, did you have any closing remarks today?
Yes, I'll just again thank all the speakers. I think this is a very important area, as I sought to introduce at the beginning that the way we consider our healthcare and our health system choices, resource allocation and way of engaging with patients and consumers can be influenced by a variety of different factors. And as a number of people have mentioned, presenters have mentioned, that historically there has not been sufficient focus on patient-centeredness in our care delivery. And I think this particular form of research and value-based healthcare, which incorporates the patient's perspective, is a significant advance forward in our research and in the ability of health services to make appropriate decisions. I think that's why I think it's very important to bring this to the table for all researchers to consider a broader range of perspectives, and particularly the consumer perspective. We can also take the term consumer or patient-centered and also look at it from the perspective of the healthcare providers. And so there's other research which Laura's engaged in, and Francesco, where the DCE approach or the preference elicitation approach is being used to identify what caregivers or clinicians prefer to be appropriate models of care or appropriate or beneficial ways to support their delivery of guideline recommended care. So I think the application of DCE approaches, analytical approaches more broadly, has got a lot to add almost every aspect of the research in terms of improving healthcare delivery and hence patient outcomes. So I'll just thank everyone again for bringing this new area of work to the table and for challenging us to some degree. Some of the questions I think are quite important in terms of having a deep understanding, not just of the process of the values and the principles of value-based healthcare and the processes of this particular form of research, but also how it then subsequently informs decision making. So that could be a topic for another day. So thanks everyone for participating. I'd like to thank all of the people who came online. I think it was in the order of 80 plus people.